post-lunch session and myofunctional therapy is a very bad combination. I just hope I'll try to keep it as interactive as possible. So at least I know everyone's not dozing off. I started with this slide because this is exactly how we feel when it comes to pediatric orthodontics or myofunctional therapy or orthopedic appliances, because we have these barriers within ourselves that, this is restricted to just the orthodontist to do, or this is restricted. I always feel there is this huge lacunae between ortho and pedo, which is such an essential link, and it is such a big missing link, even till date. I had this feeling right from my internship when I started understanding what they do in ortho and what they do in pedo. As pedodontists, I think most of you here are pedodontists. As pedodontists, you have this enormous relationship that you build with the child, and you are the best to treat them. And except for this one zone, which, orthodontists had for many years restricted among themselves. So this missing link has to be connected, because this will help the patient in a very, very big way. So unless we break our barriers, unless we break those walls and we try, we would never know. So I would humbly suggest everyone here to really go into the depth of pediatric orthodontics and try these treatment options, or at least get help, and you can work something out, at least in a smaller scale to start with. I'm sure your patients would benefit a lot more by you treating them rather than you referring them outside. So how do you diagnose and treatment plan? This is a small gist of what we plan to see today. How do you diagnose and treatment plan? How do you check for the right age for therapy, types and effects of functional appliances, and literature supporting and contradicting therapy? Now, there are a lot of slides in this lecture that are a repeat from the morning session. For those of you who were in the morning session, you would... I'm sure most of you here were in the morning session. I'm not going to elaborate on those slides. I'm going to quickly recap and run through, because I just have an hour's time. But we will focus more on the aspects that were not covered in the session in the morning. So we did this. We know class 2 malocclusion. You have skeletal, you have dental, and in skeletal, what are the parameters? We saw that. So if it is skeletal, you can have a maxillary problem, or you can have a mandibular problem, or a combination of both. Now, let us see a roadmap. So when we talk about myofunctional therapy, we are only referring to class 2 skeletal malocclusion in a large way. Of course, there are these reverse twin blocks, reverse functional appliances for class 3, which is not very popular. Like I mentioned earlier in the morning, most of the time it's a mandibular problem, and it works best with a reversible headgear. So we are not trying to work functional therapy here. So we confine functional therapy or myofunctional therapy or growth modulation. These are other terms for functional appliance therapy, growth modifications. These two, mainly a class 2 malocclusion, which has a mandibular problem. So all we need to remember for this entire session is whatever we are discussing applies to a patient who has a class 2 malocclusion, skeletal malocclusion, and is a growing patient and has a short mandible or a restricted mandible or a retrognathing mandible. Okay, so the roadmap to this myofunctional therapy will include: first, we have to identify the candidate with the problem. Then we have to diagnose. With investigations, we have to confirm the diagnosis. So we arrive at our final diagnosis. Then we have to choose the right appliance for this patient. And then we need to execute it in the right way and follow up. So this would be an ideal roadmap for a successful myofunctional therapy. So how do you identify? So the patient walks in. I'm using the same pictures, for example. The patient walks in, he has a profile like this. You know there is something really wrong, something going wrong with the facial structures. So then you first evaluate the age of the patient. Then you look whether the profile is convex, concave, straight, all those features that you read in your clinical evaluation. So he has a convex profile, which means it's like mild to severe convexity or mild convexity, depending on moderate convexity. You just make a note roughly in your head. Then you could do the 2-finger test that I showed you in the morning. You could do, is there anyone here who was not there in the morning session? Because I'm going to keep saying which we covered. So
yeah, I think it's better if somebody is there, then maybe they should put it on the chat box. Otherwise, it'll be easier. I think most of them were there in the morning.
Yeah.
Maybe one or two, if they have missed, then maybe you can do
it. If there is a doubt, they can always ask at the end, right? I'm not going to elaborate on, then we won't have time, sir. So I'm not going to elaborate on what I did in the morning.
Yeah.
But if there is any point that you've missed in the morning, you can make a note, and at the end of the session, I'll keep enough time that we can discuss. Okay. So we do the 2-finger test, and then we do facial analysis using the lines. These you will put it as profit, but then you will actually find it in any textbook. Morning, I had suggested one textbook, Laura Michelle. Even in that, you will find. If you want to, I open the chat box. Sorry. Yeah, so there are a lot of books which will give you this facial profile features, so which you can take, and you could do like true vertical, horizontal plane, and then you can check. All you're going to check is, because this is only a clinical diagnosis, right? So you're not going to make your final diagnosis here. It's just with the clinical examination you're trying to find out. So all you're going to do is just find out if the maxilla is ahead, mandible is at the back, or is there a problem. That's all you need to see at this stage. Because if you don't even identify that, you're not even going to go dig in more and do investigations and figure out, right? So first is to identify, so that you have done. And then next you do functional analysis. Of course, all that will come in your cephalometrics. You will do all the other analysis, model analysis, cephalometric analysis. I'm sure Jiva sir would have covered that. And then VTO. VTO is a very, very important aspect in functional therapy. What is a VTO, visual treatment objective? All you need to do is ask the patient to bite forward, like bring his jaw forward and bite. And you check whether his profile improves, right? If you see his profile improving, then he's an ideal candidate, and if all the other factors above are checked off, he's an ideal candidate for functional therapy. So basically you're saying when you bring his mandible forward, is his profile improving? I'm just trying to get rid of this. I'm just going to type. So just 1 second, please. I'm trying to escape the screen so I can get rid of this chat box. Okay, great. So that's with a VTO. So ideally speaking, you would be able to do VTO for all the candidates except for people who have a class 2 division 2, because in class 2 division 2, again, the upper incisors are retroclined, and it's very hard for them to bring the jaw forward. So it is not possible for you to do a VTO. However, in a class 2 division 2, unless you even bring out the upper incisors, you can't even do a treatment plan. So either you do a phase 1, bring out the upper incisors with a 2x4 appliance, or you do a fixed functional appliance where you can align the upper incisors and bring the jaw forward simultaneously. So in that case, a VTO you will not get a positive VTO. But in most of your other patients, you will get a positive VTO when you try to do the VTO test, if they are a candidate for functional appliance. So it's a very easy, quick way to find out if you want to do functional therapy. Buccinator mechanism, again, we discussed in the morning, but just a quick recap. When the mandible is placed downward, like in case of a habit, or backward, like in case of a class 2 skeletal, there is going to be constriction of the upper arch because of the strong buccinator muscle that's acting from the buccal, and there is no counter force from the tongue from inside, because the tongue is also placed, if the mandible is placed backwards, the tongue is also placed backwards. If the mandible is placed down and back, the tongue is also placed down and back. So the tongue follows the mandible, right? So because of that, there is constriction in the upper arch, which is going to cause a maxillary constriction in these patients with a class 2 skeletal malocclusion. So that's what we call the buccinator mechanism, because buccinator mechanism is the teeth are maintained in a neutral arch form because of the tongue pressure from inside and the buccinator pressure from outside, and the lips, which maintain it in a neutral arch form, which is not happening in case of a class 2 skeletal patient. So these are factors that you will look for. And as I mentioned, the 2 lines, you could even use this. This book is available online. This is again a very nice, for facial analysis, a very nice clinically oriented book that you could use. So like I mentioned in the morning, you could use a scale, you could use your 2 fingers, and then you can confirm with yourself, to see, okay, there is a problem. So choose the right investigation. So model analysis, then you'll do your OPG and CEF. And in your CEF, you'll do your basic analysis, Steiners, Tweeds. Now, Bjork and McNamara are very, very important when it comes to functional appliance and myofunctional therapy, because Bjork will give you the position of, the mandible to the cranial base. It will give you this the angle that is open or closed. So that is a very, very important analysis that you could do. McNamara, again, for any growing patient, McNamara is a very important analysis. So these 2, I would say, of course, Steiners and Tweeds will give you very basic parameters, whether, SNA, SNB, whether the maxilla is forward, mandible is backward, these basic things you can quickly find out from Steiners and Tweeds. But with regards to, is it a functional retrusion? Is it an anatomically short mandible? All that would come out from your Bjork and McNamara gives you the maxillomandibular differential, right? Which again is very, very helpful in growing patients. So these are something that you will want to need for. Then from your cephalometrics, you identify whether your maxilla is at fault or mandible is at fault. That is it a maxillary prognathism or a mandibular retrognatism, or is it a combination of both, right? And then you have to find out whether it's a low angle or high angle, because your appliance is going to depend on that. Because in most of these functional appliances, you're going to end up extruding the molars when in the trimming process, right? So that way your bite also gets corrected. But suppose it's a high angle case, then you have to be very careful. You have to give bite blocks to make sure there is no extrusion. You don't open the bite furthermore. So you need to, it's very important that we need to know that whether it's a low angle case or a high angle case or an average angle case. Then you need to know about the proclination of the upper and the lower incisors. Why? Because if it is a lower incisor that is proclined, it's actually a contraindication. Because how would you, if you have proclined lower incisors, which are actually causing a very minimum overjet, how would you even bring the jaw forward, right? Then you will have to do something for it before you give in the functional appliance. Maxillary and mandibular length, you need to know, because as I said, if there is a genetic potential for a short mandible, right, like anatomically short mandible, then it's going to be very, very hard. Even with the functional appliances work best when there is a restricting factor and you're removing the restriction and letting the mandible grow. Then, you see the saddle angle, that again, you will see it in the Bjork's analysis. So these are factors that you actually take into consideration when you are investigating a patient. Now, as I mentioned, even in my first lecture, age is the most important factor. Like we always say, right, age doesn't matter unless you're cheese, but in this case, it's even worse than cheese. Age really matters a lot when it comes to the patients. Like back there, like in Canada, cheese is very, very I would say almost like a staple food. They eat different kinds of cheese, right? So for them, the age of the cheese really, really, really matters. People go and try and get like the older version of the cheese. But here you have to attack the patient at the right age, or we're going to like lose that. Even 6 months makes a big difference in myofunctional therapy when it comes to age. That's why we focus so much on what age do we actually start treatment in the first lecture, which I will recap again. So as we know, growth gets completed in the various dimensions, like we saw in the morning: transverse, sagittal, and vertical. So we have to target the mandible at pubertal growth spurt. Okay, that's when the peak velocity of the mandible is maximum. So to target that, we need to attend to it just prior to the pubertal growth spurt. So we let the patient adapt to the appliance. So that's the reason why I mentioned late mixed dentition. But to be more precise and clear, anywhere after 8.5 years, say 9 years, would be an ideal age to drop in a function. If you drop in at 8.5, by 9.5, they would have the appliance in place, and then the peak velocity would hit, and you will get the maximum benefit out of the patient. This is for mandibular correction, right? We are talking about. But if we are talking about maxillary, then it's a totally different picture. You have to start as early as possible. So when the mandible is at fault, we start just prior to pubertal spurt, functional appliance. Now, why late mixed dentition? Because the E-space still exists. There are authors who claim a few points, so I've just mentioned it here. But ideally speaking, it is because of the growth spurt. Approximately 80% of the patients are still treatable with this at this stage with non-extraction. The treatment can be completed in one phase. The orthodontist can still capitalize on growth. Now, treatment can be completed in one phase is again not a surety, because it all depends on what is the occlusion they have, what kind of treatment we're trying to achieve. So that they have mentioned in the article, but I would not strongly emphasize on that point. There are authors who also have different views on age, but I have just mentioned them over there just for your reference. CVMI, the cervical vertebrae maturation index, is one of the most commonly, I would say, recently used index for growth. Like I know earlier we used to do skeletal maturity indicators, hand wrist X-rays, which are not followed anymore. This with CVMI, the advantage is you're not subjecting the patient to an extra radiograph because it comes along with your lateral ceph. You can do it on the lateral ceph, and it's much more an easier analysis, I feel, in comparison to your hand wrist X-rays. So the ideal biologic indicator for individual mandibular skeletal growth should be characterized by at least 5 features, right? Yeah. So the peak, it should detect the peak in the mandibular growth. It should you should not have additional exposure, X-ray exposures. There should be an ease in recording, and there should be a consistency in interpretation of the data. And finally, it should have a definable stage or phase. Like if it keeps overlapping, right, then again it gets very confusing. So you should have definitive stages that will say, okay, this is stage 1, 2, 3, and then how you take it forward. Now, how do you identify? You have the shape of the vertebrae and you have the concavity. Now, let me see if I have a picture. Do I have a ceph here? 1 second. I'm just going to try to see if I can explain it on the ceph. There. So, okay, I've cut this picture. I'm so sorry. But then if you see the vertebrae, right, the base of the vertebrae, you will actually, in this, you will see the third one is almost flat. But if you notice the first one, you will see a slight concavity on it, right? So that is what we refer to as concavity, the base of the vertebrae, I'm saying. And the other is the shape of the vertebrae. Now, these are the only 2 things that you're going to take into consideration when you're doing your CVMI. Yeah, so the shape of the vertebrae can be trapezoid, square, rectangular horizontal, or rectangular vertical. So you understand the shapes, right? So trapezoid, then it will become a square, then it will become rectangular, but it will be the what is this is length, right? Yeah, length will be more, breadth will be shorter. Rectangular vertical, where the length is short and the breadth is longer. So these are the stages in the shapes of the vertebrae. Then you have if you read the article, it's very, very simple to understand. I think I mentioned the article in the next slide. But I'm just explaining because we are already doing this. And then the concavity, whether it is flat or whether it is concave, the lower border of the vertebrae. So if you notice the stages, if it is all flat, all trapezoid, then 1 to 2 years for peak mandibular growth, right? That is stage 1. Stage 2 is concavity seen in C2, C3 and C4 are still flat and all are trapezoid in shape. Then it is 1 year to peak mandibular growth. So you still have 1 year's time. So when you see the patient, you have roughly an idea when you want to start the treatment. Say they come at 6 or 7 years. If you do this CVMI, you will know, okay, you can tell them, I still have 2 more years, so come and see me in a year's time, or, however you want to schedule it. If you see them at stage 3, that is peak mandibular growth. So you don't want to wait till stage 3. You might want to see them at the end of stage 2 to actually start off, right? So if in stage 3, you will see C2 and C3 would be concave already. The C4 will still be flat. And then the C3 will be rectangular horizontal, or it could be trapezoid. And then C4 again could be rectangular horizontal or trapezoid. So that means it's peak mandibular growth. Now, once everything becomes concave and rectangular horizontal, then the peak mandibular growth has occurred within 1 to 2 years. So at this time, you still have some room to drop in a fixed functional appliance. You might still benefit out of fixed functional appliances. The stage 5 and 6 means you have already lost that time and, growth is completed. I mean, I still know at stage 5 when people try with fixed functional appliances, you might get more of a dental movement rather than a skeletal movement. But the ideal would be stage 2 and stage 3 when you want to drop in your functional appliances. And if at all you want to do like a fixed functional, you could do stage 3 and even stage 4. Stage 5, yes, you could still achieve some dental correction. So the 6 stages and its interpretation or explanation. Stage 1 and 2, 1 to 2 years of peak mandibular growth. Stage 2, 1 year of peak mandibular growth. 3 is actually the peak mandibular growth. 4 is 1 year or 2 years before the peak mandibular growth has occurred. And I mean, it should be after. Sorry, I made a mistake there. Stage 5 is 1 year at least since peak mandibular growth has completed. So orthodontic implication would be class 2 cases, you want to target stage 3, and class 3 cases, you want to, stage 3, you could even do end of stage 2, like I mentioned, so that you get them used to the appliance. But class 3 cases, you want to target them at stage 1 and 2 itself before, the sutures start to interdigitate. And vertical maxillary excess, you could do it at stage 3. We saw, right, that vertical maxillary sprint that we give, so that you could do it at stage 3. So that's the article. It's a very nice article where you can very self-explained, and you just read it once, you will be able to understand the entire analysis and you will be able to perform it. So by now, the patient has a clinical issue, and then you've done your Ceph model analysis and you've identified, okay, there is, say, a mandibular problem, right? It's a class 2 skeletal with a mandibular problem. You've identified what is the skeletal age of the patient by now using your CBMI index. So you're all set and you've made your final diagnosis. Class 2 skeletal with mandibular retrognathism, and the patient is in the skeletal age with this dental issues. So that's your final diagnosis. Now you have arrived at the final diagnosis. So in the roadmap, you have checked 4 points: identified, diagnosed, you've chosen the right investigation, including your CVMI, and you've done your diagnosis. Now it is the time where you choose what appliance to drop it. Now we know it is a case where the mandible is at fault, mandible is small, so you have to bring it forward. So to bring the mandible forward, we only have functional appliances, fixed functional appliances. Of course, you have your aligners, your trainers, myofunctional trainers and all that. But let's get into it. The main thing is functional appliances, because see, with my like sir was mentioning in the morning, he was saying myo brace and stuff, right? With all of those trainers, what you're basically doing is you're bringing your jaw forward and fixing it in a position, and then you're allowing the teeth and the like, you're not individually addressing to specific issues, right? But with it does work. It does work in terms of bringing the mandible forward. I don't deny, but is it as effective as a functional appliance? Is still debated, right? Because once you bring the mandible forward, your airway opens up, your mandible comes forward, your profile improves. But I think someone is.
I'll mute everybody. Madam. 1 second. Somebody is traveling.
Okay. So
go ahead. Madam.
Okay, sir. Sorry. So if how much of individual teeth movement are we going to achieve is again debatable. Anyway, that's a huge debatable, controversial topic. So, but let's not get into it right now. So with myofunctional therapy, what you're basically doing is you're not just correcting teeth, you're bringing jaw forward. So you're retraining the muscles to a new adaptive position. In that process, you're letting teeth extrude and align and settle in the new position. So the teeth are also achieving new position. You're improving the patient's soft tissue profile. You're also changing the functional pattern of the patient. So now if you go back to theory, you will see that it follows this functional matrix theory, which says that when you work around the soft tissues, when there is change in soft tissues, there's change in function, there's change in soft tissues, there's change in soft tissues, change in function. So it coexists, right? Like because of your soft tissues, your function also will alter. So that is how with functional therapy, airway increases, airway improves, and patient gets so much better in terms of function as well. Parafunctional habits reduce and so many other benefits out of it, right? So choosing the right appliance is what we're going to see next. So going back to some history, Wolff's Law, and I don't want to elaborate on these. These are just because I have to put them for completion's sake. But to give it to you in a gist, influence of natural forces and functional stimulation on form is the key to functional myofunctional therapy. Anything to do with function and soft tissues is interrelated, and the bone and the trajectories will follow those patterns. So in the olden days, they thought everything follows the bone, but actually the bone and structures follow form and function, right? So that is what we are moving towards in terms of myofunctional therapy. So that's also the reason why myofunctional exercises work brilliantly. So there is this whole concept now with myofunctional training and exercises. This is again in the West, it's catching up. But will that alone help in treating these patients is again not proven yet. That is an adjunctive procedure that you do along with your myofunctional therapy, with your appliances, that will hasten, speed in, and the process of the treatment. But that alone is not going to be sufficient as of now, right? So the purpose of a functional appliance, let's see what effect a functional appliance actually has. One, to bring the mandible forward. That is the primary goal of a functional appliance. You want the mandible to come forward. Now, Because the mandible comes forward, the tongue also comes forward, so it helps in airway. Then, because the mandible comes forward, obviously the mandibular teeth also comes forward. You can't just keep the teeth at the back and move the mandible forward. Hence, proclination of mandibular incisors, thus contraindicated in already proclined anteriors, mandibular anterior. So that's why I mentioned earlier, proclination of lower mandibular teeth is a contraindication, because when you bring the mandible, already it's going to come forward. So if it's already forward, you're going to get a reverse overbite. So you'll have to correct the proclination before you actually bring the mandible forward. Then you'll have supraeruption of posterior teeth, thus increasing the vertical dimension of the face, because most of the time these cases you will have a lower facial height or a deep bite. So in a long face, this is actually contraindicated. But you have some modifications for these functional appliances where you put like a splint on the molars to actually hold, we call it the V activator. You would have seen it in the textbooks. So they actually hold the teeth, preventing them from supraerupting. Open bite modifications, they are called, and it will just bring the mandible forward. But even then, you will have a little bit of bite opening tendency, for which you will have to see. And again, the vertical excess in a class 2 is a smaller percentage compared to the horizontal growth pattern in a class 2. If you see, predominantly it will be a horizontal growth pattern, but in Indian population, we do see a lot of vertical growth pattern as well. So you have to address it with a little bit of caution, but it's still doable. And fixed functional appliances work brilliantly in that, because then you have more control, because you have braces on, you have more control in terms of holding the teeth as well, right? And then even in Frankel, they have a modification for open bite cases. So then comes your TMJ remodeling, condylar growth, shortening of the LPMs, because I told you, right, the lateral pterygoid muscle actually constricts because lateral pterygoid muscle's action is bring the mandible forward. So when basically the action is performed, the muscle is getting constricted. So we keep the lateral pterygoid muscle in front for a long time. Obviously, you're going to have a significant amount of constriction in the LPM muscle. Now, if any of you is interested in research in this area, Rabi et al. Has done enormous studies in cellular level and structural level of TMJ, condyle, and how when the mandible is brought forward. There's enormous amount of articles in this topic if you want to get into it. But in gist, they have shown that functional appliances work in a cellular level. They do cause a lot of TMJ remodeling. Condylar growth has been shown in some studies, and then the shortening of LPM also has been proved in those cellular level studies by Rabi et al. So effects on the mandible in the sagittal dimension and the condylar cartilage, you'll see increase in mandibular length. This is post-functional therapy, I'm saying. You'll see an evident increase in condylar length. How do you find this cephalometrically? Your COGN and COPOG linear measurements would be increased. You'll have growth in the condylar cartilage. There is change in condylar trabecular orientation. We call it the Stutzman angle. So there is a change in that trabecular orientation. Additional subperiosteal ossification of the posterior border of the mandible is also evident. Changes in the ramus height is evident. Forward positioning of the mandible is obviously evident clinically and cephalometrically. So these are the changes that you see in the sagittal anteroposterior dimension post functional therapy. So effects of functional appliance on the vertical dimension. So studies have shown that it increases in the mandibular ramus height with functional appliance therapy, thus contributing to an increase in a posterior facial height. So as I mentioned, a lot of these patients have a very low and lower facial height, and then it is significantly shown to increase posterior facial height. So you have studies that have reported all of these articles. If anybody wants to see, go through, you could. So effects of functional appliances on the maxilla. Now, Do functional appliances really have any effect on maxilla? No, but they have like a headgear-like effect. Now, usually in orthodontics, for any movement to happen, you should have a counter movement that takes place. That's what we call anchorage, right? You have to take support from something which will have a counter force, but it will hold on to it and then the movement happens. Now, this is very similar with the functional appliance. When you pulling the mandible forward, it obviously has a counter restrictive movement on the maxilla. Any of your appliances, if you look at it, it'll have a counter restricting movement, especially when they are monoblocks, right? So that is why they claim that functional appliances have a headgear like effect on the maxilla, restricting the maxillary component which greatly aids in reducing the class 2. Why do we say this is, like if when you let the mandible come forward, right, and you restrict the maxilla, it will actually now for example, say he has a retrognathing mandible and then the maxilla is growing, normally, and then it keeps growing. What happens is, because of the restricted mandible, even the normal maxilla will have a tendency to look prognatic because his mandible is restricted. Now, when you are bringing this mandible forward and restricting the maxillary component, it is like a win-win situation that you are creating over there, because you're reducing the amount of skeletal class 2 eventually, right? I'm not saying the maxilla is moving distally, effectively moving distal. No, it is not. Even with a headgear, it is not. But at least you're reducing the amount of forward movement of the maxilla, so that way, in a whole, you are reducing the amount of skeletal class 2. So again, you have Panchers who've done. Hans Panchers did a lot of work in functional appliances, especially with fixed functional. He was one of the few founders of, I would not say founders, inventors of fixed functional therapy, Herbst appliance. So effects of functional appliances on maxillary and mandibular dentition. So long we saw what effect it has on the sagittal plane, on the vertical plane in the skeletal structures, right? Now let's see what it has on the dentition. So mesial migration of mandibular teeth, because obviously mandible is coming forward, distal movement of the maxillary molar. Now, this headgear-like effect, though it doesn't have an effect on the maxilla to push it distally, it obviously has effect on the teeth. The teeth will easily move backwards. So it will have a distalizing component. Unless you don't want it to move and hold it, it will have a distal force on the maxillary molars. Proclination of mandibular incisors, retroclination of maxillary incisors, again, right, like counter movement, reduction of overjet, correction of class 2 molar, and supra-eruption of mandibular molars. Now, that's the base how functional appliances work. Unless you don't want them to supra-erupt, you will have to hold them on. So, effects of functional appliance of TMJ and glenoid fossa. Studies have shown significant amount of glenoid fossa remodeling functional appliances. The glenoid fossa remodeling generally occurs posterior and superior surfaces, thus enabling the condylar growth. So I know that's too much of theory, but then I'll just give a gist on this mode of action and quickly move on to some clinical scenarios. So mode of action, you have different theories that have been suggested for myofunctional therapy, but the most popular and the most widely accepted theory would be the functional matrix theory, which we just discussed a couple of slides back. So now going on to the roadmap, we go ahead and make an impression, right? Now, once we make an impression, we have to make a construction bite. That is our stage 2. So we have identified the patient for functional appliance. Now you're going to take an impression and you take a construction bite for functional appliance. Now with construction bite, there are a couple of things I want to say before we go to the next slide. One key thing, I mean, you can use bite registration base, or you could use the wax that is made into a horseshoe, like a rolled up wax made into a horseshoe. Now, the construction bite is the most critical step. I think I added in your pre-test, there was a question. It is the most critical step in your functional appliance fabrication, because whatever you make on your bite is what is going to come out in your acrylic, right? So the amount of forward positioning of the mandible is recorded in your construction bite. So that is the key. And I'm sure all of you know how to make it, but just to recap, you need to make a rolled up wax with a horseshoe shaped, in a horseshoe shape. You warm it nicely, so you soften it, and then you temper it so you don't burn the patient's mouth. And then, of course, you've already marked your midlines on the cast. You put this in the patient's mouth. Now, before you put this, you would have to train the patient to bite in the position that you want them to bite. How much forward you bring it, right? If you're bringing it to class 1 or you're bringing it 70% forward. So you have to have the picture first in mind, decide it on the cast, and now train the patient to keep biting that way and make them bite in a position that you want ideally and fix it, right? And once you fixed it, on the sides, now the wax is popping out on the side, just flatten it out using your fingers so it makes those indentations on the teeth. So when you take it out and put it on the cast, you can easily fix it on the cast. Now, if you don't do that flattening part, right, then you will miss it when you place it on your cast. So once you've transferred it to the cast, now you send it to the lab and ask them to fabricate the appliance of your choice. Now the next question comes, how would you decide how much to bring forward? Now, again, there are lots of studies done on this. The authors of the various appliances itself have given various concepts to bring it forward. So if you're giving an activator, you usually bring the molars to class 1. If you're doing a bionator, according to the bionator principles, you either bring it to edge and you give only a 3 millimeter vertical clearance. That is what you do with a bionator. For a Frankel, it is always a stepwise advancement. You cannot advance a lot with a Frankel. It's very, very uncomfortable for the patient. So it's a stepwise advancement. So every time you have to do 2 to 3 millimeters of work, and it's very minimal vertical clearance, right? Frankel works on a very minimal. So you do stepwise, and then you do 2 to 3 millimeters vertical clearance, and then again you have to refabricate. That's one drawback with Frankel. Then with terms of twin block, Clark says you can do 70% sagittal. That is, if 10 millimeters is your overjet, you can bring up to 7 millimeters. So 70% sagittal and 5 millimeters vertical at the premolar region. That is, so you have to bring it to 7 millimeters and make sure there is a vertical clearance of 5 millimeters at the premolar region. So for this, how do you check this is, in a patient's mouth, you can use a divider, or you can put the wax again on the cast and use 2 points. So what we used to do, we used to actually have 2 stickers placed on the patient's mouth, like, those micropore with dots to make sure the vertical clearance is 5 mm before and after. You could again counter check this using your cast as well. So that is with a twin block. And with a Herbst appliance, it is 2 to 3 millimeters sagittal. And then again, you're going to do a vertical of 3 to 4 millimeters. So Herbst is nothing but your fixed functional appliance. So you need that minimum vertical clearance. Otherwise, even with a fixed functional appliance, it will pop out the whichever you're using, the pivot and the socket, right? It'll pop. So in twin block, again, if you don't have that minimum vertical clearance, right, the patient will end up biting on the blocks. So there will not be any sagittal movement. So these are the various bite options that you have depending on what appliance you pick. So because I assume you'll use more of twin block, then you will have to stick to 70% of the so stick to whatever the author has given for that particular appliance, because that's when you will get the best from that appliance. So the types of appliance, I don't think anyone uses activator. Maybe very few clinicians still use Frankel. I doubt it. But bionator, twin block, and bionator is my personal preference, as I said, because I feel it is a beautiful combination to work on the muzzle and the teeth. Twin block also is inevitable. Even with bionator, you might have to, add it up with a twin block. For the sagittal correction, twin block is beautiful. And also patient compliance is so much more with a twin block. And then your fixed functional appliances come very handy, especially when you've lost that time with the patient. So I don't know if you want me to go into this history and all that, but again, Anderson and Hopple activator, they were the ones who found the activator to activate the muscle forces. It is bulky, only nighttime wear is possible because it's a monologue, right? Like monoblock. So you cannot have the patient wear this through the day. They can't talk and eat and stuff. So eating anyway, they will remove, but function is not possible and it's very uncomfortable. But whereas in a bionator, the equilibrium between the tongue and the circumoral muscle influences shape the dental arches and intercuspation. Tongue is a center of the reflex activity in the oral cavity, and it keeps the muscles away and it helps the tongue to perform. So you see that the coffin spring that is placed, right? That also helps in training the tongue. So that way the muscles are taken into account, and it helps in function and form and function as well. So for the bionator, you do an edge-to-edge bite. You have to bring the incisors to edge. That is the bite registration for the bionator, and you give a 3 millimeter vertical clearance at the premolar region. So that's how a bionator is placed. You can do a bionator with the lip pads. In this, it is with the lip pads. So you keep the lips also away. So that way there is no restriction from any muscle. The labial bow takes care of the buccinator, which is kept away. The tongue is taken care of by the coffin spring. So all the muscles are taken care of, and you are allowing the mandible to catch up on its growth, and you're letting the teeth to move as well. So that is how the bionator works. I humbly recommend people to try it, and you will see the benefits of it. But yes, sometimes if the overjet like in this patient, we knew we have to follow up with the twin block, because if the overjet is not much, you might not have to. The bionator itself will do good enough. But in this boy, the overjet was quite a bit. So we knew that bionator is not going to be sufficient enough to give that push. So we actually changed it once the lip trap was eliminated. We changed it to a twin block to get that sagittal push. So modulation of muscle activity of the tongue, elimination of abnormal influences of perioral musculature, stimulation of myotactic muscle activity and isotonic muscle activity, no vertical component except for guiding eruption of teeth, no viscoelastic response, prevention of deleterious parafunctional activity at night. So these are some of the effects and benefits that you will get out of a bionator. So vertical component also is less. That's why we do only a 3 millimeter opening, right? So that way you're not supra-erupting teeth like how you do in case of a twin block. Frankel, again, it's a completely tissue bone appliance, and it works on the buccinator mechanism beautifully. That's why they have the buccal shields. It keeps it away. It's a brilliantly constructed appliance, no doubt. Only thing is it's expensive. You need to refabricate, reactivate it, every time, because you can only do incremental advancements. Patient's comfort is very, very less with a Frankel. Anyways, you'll have to know it. So stepwise advancement and 2 to 3 millimeters of vertical clearance, very minimal vertical clearance. Again, you don't allow too much of supra-eruption of teeth. Going on to twin block, given by William Clark. It works on occlusion and inclines. That's the basic principle by which twin block works. Very, very popular. You can wear it 24 hours. It's 2 different blocks, easy to fabricate and easy to adjust. You could do multiple modifications with a twin block. Like I mentioned, Frankel itself, Frankel and bionator has an expansion component. That's why you have that coffin spring in the bionator. but it's not as effective as what you will get with a twin block, right? Because in a twin block, you can drop in a expansion screw itself, and you can cause effective palatal expansion. Like I mentioned, in most of these cases, class 2 division 1 skeletal cases, you will see a palatal constriction because of the factors that we saw before. So you will have to expand the maxillary arch to accommodate the broader portion of the mandible. So when you do a twin block as well, so you can drop in a construction screw to do the expansion. So you do a construction bite, like I mentioned, the construction bite is going to be 70% of your sagittal advancement. Like say, whatever is your overjet, 70% of it is going to be your sagittal advancement, and it's going to be a 5 millimeter clearance at the premolar region, and then your inclines in the upper and the lower planes, like you see in the picture. So it's going to come forward and sit beautifully on the incline. So class 2 division 1 and div 2 cases you can do, because in div 2 cases there is an option where you do I'll show you that picture. I think I have it here. In division 2, you have this option of placing a screw to cause to procline the upper anteriors. So that way you can procline the anteriors and allow for sagittal correction. So that's with the construction bite and the case selection for twin block. Then you have an active phase, and you have a trimming phase, and then you have a support phase. So in the active phase, you're going to allow the patient to keep wearing for the forward movement. You check your pterygoid reflex, see if they are wearing it consistently. Then you will have to do the expansion, right? So you have to do trimming of the inclines depending on the overbite. See, if your overbite is already a lot, like meaning the patient has almost a tendency to open bite, then you're going to restrict your trimming. But then if you want supraeruption of teeth, then you're going to trim more. And then you're going to expand the screws for transfers and sagittal correction. Like I showed you, if you need proclination of incisors, you're going to do even sagittal screws. Otherwise, just transverse screws. And then you're going to do your trimming phase. You're going to constantly keep trimming to allow for supraeruption of your posterior. So you do it in sequence. First you trim the upper block, then you trim, you allow for the molar eruption completely, and then you trim the lower block to allow for your canines and your upper premolars to settle in. So basically, however the teeth you want to settle it in, you can trim accordingly and then allow the teeth to supraerupt. And then in the support phase, you just give, you don't give any blocks, you just allow all the teeth to settle in, but you will just give a plate so that you will hold it for a while. Then you have a retention phase, which they have to wear it at nights so that the teeth settle in furthermore. So I think we discussed the construction bite earlier, so I'm skipping that slide. So how much forward? So 10 millimeters or less in overjet. You can do edge-to-edge bite or 2 millimeter clearance at the incisors. If it is greater than 10 millimeters, then you do 70% of the protrusive distance, because the condyle cannot take anything more than that, right? You have to stay well within the adaptive capability of the condyle. So that is why you have these two options. So that's why I said if it is 10 millimeters, you go up to 7 millimeters. But if it is less, say if it's only 5 millimeters or 6 millimeters of overjet, then you could even do edge to edge. Because if you do edge to edge in a 10 millimeter, it will be too much for the condyle to accept it. As the medial capsular ligament can displace the articular disc medially and distally. So you don't want that to happen. So vertical component, how much beyond rest position? So 2 millimeters at the incisor position, 5 millimeters at the premolar region. Too less, patient can bite on the block. So if your vertical clearance is too less, like I mentioned, they'll end up biting on the blocks. And if it is too high, then it will displace the appliance itself. So it should be in an ideal position that the patient can keep coming, bringing the lower forward and biting comfortably. In deep bite cases, you could do edge to edge, and in open bite cases, little more than 2 millimeters, so that you have to be careful of that also, right? How much of supraeruption can you do? So in a div 2 patient, like I said before, we can give those sagittal screws to correct it, and then you could also use of sagittal screws for proclination of maxillary incisors. You could also do a 2x4 appliance prior to functional therapy, and then just stick to regular twin blocks with transverse screws. A VTO is a must to ensure patient profile improves. A VTO plays a very significant role in a class 2 div 2, right? More than class 2 div 1, because in class 2 div 1, it's going to improve. But in a class 2 division 2, usually the soft tissue profile is very, very normal in the patient. You won't see a very convex profile. So in this patient, actually, a VTO will benefit you to see how much you want to bring it forward, if you want to bring it forward, or, depending on that. So you will have to do a VTO in the patient to check for its profile improvement. So we discussed that. So I'm skipping that. So we do sagittal screws, or you could do a 2x4 appliance, whichever is comfortable. When it comes to an expander, why do you use an expander? We discussed this before, the buccinator mechanism, how it constricts the arch and how you need to expand the arch to accommodate for the broader portion of the mandible. So these are reasons why you want to use an expander and expand the arch before you also do your sagittal correction. You also do have bonded twin blocks, because again, patient compliance is a constraint when it comes to the mobile twin blocks. You have to, trust the patient to wear the appliances, but with bonded twin blocks, you do have other hygiene issues as well. So not very popular, but they have tried some modifications as to, attach it to the tubes and stuff. These are nothing but like your trainers these days, right? Like the popular trainers these days. Basically, what they do is they bring the jaw forward and they kind of splint the upper and the lower teeth together, like the boxing appliances that boxers wear, right, before they go for a fight, something like that. It looks like that. So these were very old concepts, which is getting very popular these days. But of course, these days they include other myofunctional exercises and other things along with the trainers to help, but they don't have independent tooth movement, but you don't have control on independent tooth movement, but it does have sagittal action, and then eventually you lead to supraeruption, and then you also bring the mandible forward and open up the airway and stuff. So these are some possibilities in the so this is orthopedic traction, which we already discussed. So I'm going to skip that in the first session. So this is with retrognathic mandible in class 2 skeletal malocclusion. So what we saw till now is when there is a short mandible, we use certain functional appliances and we try to work around these functional appliances depending on the need that you have for the patient. So there is no one clear-cut rule saying, okay, this appliance is what that works, this doesn't work. So this patient, again, we saw in the morning, he actually has a combination of maxillary and mandibular problem. He had a prognatic maxilla. He also had a retrognatic mandible. So if you see his Ceph, you'll actually see that on the Ceph. So for him, we actually dropped in a twin block to address to the mandibular problem. And we also gave him a cervical put headgear so that we could allow for supraeruption of teeth, because he had a deep bite. It will also correct the deep bite, and it will hold the maxilla, prognatic tendency of the maxilla as well. So it works in combination for the class 2 correction. So the ability to simplify means to eliminate the unnecessary so the necessary may speak. I think this holds very, very true in terms of functional therapy. So I hope you don't have this. We still have some things to do with terms of fixed functional appliances, but I hope so far we are on track and we are good to go. So with fixed functional therapy, the main advantage with fixed functional therapy when compared to all these removable appliances is you don't have to solely rely on patient's compliance. It is there in the mouth, like someone had asked me in the first session, how long to wear. The more they wear, the better effect you get, right? So with fixed functional therapy, it is there technically 24 hours. So you have the effect all around the clock, and obviously the faster it is. But the only thing is with fixed functional therapy, how much of skeletal movement we achieve when compared to dental movement is again questionable, only because we are addressing to the patient very late on in the late mixed dentition stage, because for fixed therapy you need your permanent teeth to be in place, right? So so that is one factor that we have to keep in mind. But having said that, studies have shown a lot of difference. Yes, the dental improves, but the skeletal, as long as the profile improves for the patient's happy. So that way patient acceptance level is high. But if you see like studies like with cephalometric comparisons of how much of mandibular growth is achieved and all that, definitely functional appliances which are started much earlier have shown good results. So fixed functional therapy has had a long history. It's evolved so much. In fact, the recent ones from Ormco are, Ormco is a company that makes these fixed functional as well. So they have brought about this very simple, I don't have a picture of it, very simple. I saw it the other day. I have not used it personally, but it's very simple and nice. It's just on the molars and it's so simple to snap on and work with it. But apart from that, I've used Forces, Herbs, and all these are conventional ones. Forces is from 3M. That is also a pretty nice appliance, fixed functional appliance that you could use. So the basic concept is you have something holding the mandible forward, and it is fixed right on the posteriors, and in the anteriors you actually have your regular braces which helps in aligning. So in say in class 2 division 2 cases where you want to procline the incisors, you could do it simultaneously, so that way the patient's total treatment time also comes down. So these are just pictures of conventional Herbst appliance. And how do you select patients for fixed functional? So usually non-compliant patients who are who will not wear removable appliances have to be falling under fixed functional therapy. Patients at the end of growth period, class 2 malocclusion with retrognatic mandible, of course, that is the criteria. You should have that. Horizontal growth pattern again is more ideal. Even for functional therapy, horizontal growth pattern is ideal. But in a vertical patient, what do? You can't just tell them I wouldn't treat you, right? So we need to work some modifications to see what possible. But the best outcome that you will get is with the horizontal growth pattern. Well-aligned arches, absence of crowding or proclination of the lower incisors. Now, if that is not there, then you achieve it with your phase 1, and then you put in your functional appliance. And then how do you do it? You have your first, second, and third visit. So you this is for the banded type. You do also have bonded types of appliances nowadays. So you make an impression, you put the patient on separators, call them back, band them. Once before banding, you make your construction bite for your functional appliance. And once you do the construction bite, you choose the size of the appliance that you want to drop in, then place the bands and fix the appliance. It depends on each appliance. Herbst is different from Poses, and the Ormco one is slightly different. So each one comes with your instruction manual. You follow that and you place the appliance. Now you can choose to wait for another visit to strap up, or you could do it simultaneously depending on the need again, right? So if you are correcting your incisor inclination before this, then you will have to do it ahead of time, or you could choose to do it at a later stage. So with sagittal, how much of bite registration? So for sagittal, you will do about 2 to 3 millimeters and vertical clearance about 3 to 4 millimeters for herbs. And according to Panchers, you do stepwise, single step advancement. You don't do stepwise advancement. One single go, you do an advancement. So that's a modification Panchers gave for the same herb step lines. So the laboratory procedure I'm not going into because you don't use this anymore. You get prefabricated appliances in different sizes, like Forces has different sizes. You just have to pick the size. But this is how it all started off. They used to prefabricate it depending on the amount of sagittal correction you need for each patient. So I'm not sure if you want me to cover this in detail, but how the anchorage works in a fixed functional appliance. So earlier they used to just take anchor from 2 or 3 teeth, half with a half rounded or round wire, and then they'll place the appliance. Then you can also do the same thing in the lower, right? So that's a partial anchorage technique. And then you have total anchorage where the entire arch is involved. You bracket the entire arch with bands and bonds, and then you take total anchorage to help in the correction, right? And then fixing the telescopes will be your final visit when you've already measured, you prefabricated the telescopes, and then finally you fix the telescopes in place. So that telescopes is what is going to bring your jaw forward. So what instructions would you give? Muscle discomfort and eating difficulties for 1 to 2 weeks. They will have 3 months adaptation period is allowed. Avoid sticky and hard food. Telescopic elements get if the telescopic elements get dislodged, you will have to train the patient as to what to do. Just give me a second, please.
Yeah, Meera, you can open that door for her.
I'm so sorry. Please excuse me for this. So, yeah, so you train the patient as to what happens if the telescopes, because it's a very, sometimes with sagittal movement, right? When the telescopes become shorter, like meaning the mandible is already forward, then you'll have to add some more, right? So then the telescopes tend to get dislodged. So then you can, in fact, they come to a point where they will be able to automatically slip it in, but you'll have to train them for it. So these are instructions that you will want to give them in your third visit. And then this only applies to your herbs appliance. It might not apply to the others. So how do you activate when the telescopes have already achieved its sagittal movement? So working of the herbs, it is very, very simple. Herbs or any functional appliance. I've just put herbs as an example here. But the mode of action is very, very similar to all the other functional appliances. So it has a mesial force component on the mandible. And obviously it has a restrictive headgear effect on the maxilla as well. And that brings about the reduction in skeletal class 2. So these are some of the studies where we have noticed the changes in how much of mandibular growth has achieved with fixed functional appliances and how much of restrictive growth has happened in terms of maxilla. So you will see the difference here. And even in terms of your mandibular length, right? Your COPG length, your COGN length, all that has significantly increased with fixed functional therapy. And there is a downward tilt in the occlusal plane, which has been noticed in vertical changes with fixed functional therapy. So it's about, it varies greatly between 1.5 to 5 degrees. So when you talk about transverse changes, it increases the maxillary intercanine width, intermolar width, and arch length. And obviously, because as I mentioned, all of these functional appliances will have an expansion component incorporated some way or the other, because it has to accommodate for the mandible. Soft tissue changes, you will see upper length retruded during the treatment. You will see lower lip remained unchanged, or sometimes there will be a mild retrusion even in your lower lip. And then overall, the convexity just improves. Now, the lower lip protrusion depends on the proclination of the lower incisors, whether the patient had proclined incisors or not. Otherwise, if they had a pride incisors, you might not see much changes with your lower lip. Dentition, very, very similar to your functional appliances. You will have mesial movement of the mandibular molars, distal movement of maxillary molars. Again, with incisors, uppers will retrocline. Suppose if it's a diff 2, then it will procline. And then lower mandibular incisors will have a tendency to proclination. So if it is already proclined, then you would have corrected that in your phase 1. Overbite correction by intrusion of mandibular incisors is enhanced by eruption of mandibular posteriors, right? Molars. So again, how much of supra-eruption you want, how much of bite correction you want is very, very specific to each patient. Effect on the condyle, it is also proven to be effective on the condyle, meaning there is, you would see evident growth in the TMJ. Treatment phases, class 2 division 1 orthopedic phase and orthodontic phase, but in class 2 division 2 cases you have an orthodontic phase, orthopedic phase, and again an orthodontic phase. Why? Because basically we have to procline the incisors before we do any form of orthopedic correction like sagittal correction. So ideal time to use herbs is again pubertal growth spurt, which is the most ideal when the maximum peak velocity is present, as growth of the condyle is the greatest. Later, the better is occlusal stability. Now, this is why, like, some people ask me, if you say fixed function is good because it's there in the mouth all the time, why don't we give it early on? Why do we wait till the end, or very close to the pubertal spurt, or midway, or even close to the end of pubertal spurt? Is because more the permanent teeth, more occlusal stability, better is the performance of a fixed functional appliance. So it has its own drawbacks, right? So we can't give it early on. So that is the reason why you wait till almost just before end of growth spurt, and you could. So that's why I mentioned even in stage C5, you could still use your fixed functional appliance, C4 and C5, for at least for dental changes you will achieve in C5. Right? Early and mixed dentition, it is not preferred. Like I mentioned, we need permanent teeth for its stability. So what about the relapse? Occlusal, if you have good occlusal stability, lip tongue habit, and early treatment, it is, again, it depends on how much of muzzle tone, how much of aberrant muzzle activity the patient had. It all depends on that. But the more the occlusal stability, the better would be your, or less would be your relapse tendency. Retention, again, is very, very important, whether it is functional therapy followed by phase 2 treatment, or it is fixed functional therapy where it is one phase treatment. Retention is very important. Until growth completes, you will have to put them on retainers. Anderson actually used the activator itself as a retainer until growth finished. So that was his concept of retention. So with modifications, you have various modifications even with herbs. You could do a splinted herbs. You could add, you could add it to stainless steel crowns. there were flip-flop modifications. But then now herbs is more outdated because it's very cumbersome to fabricate it. So now they use forces, but in terms of forces and the recent one with Omco, they are all company brand specific, right? So it comes with an instruction manual. You don't really see it in textbooks. But herbs and all were conventional appliances. So most of these studies are done with these. That's the reason I added about herbs. And then you have specific protocols to follow and fabrication techniques. So that's the reason it is there in the presentation. So the advantage with these fixed functional is 24-hour action, easy tolerance, maxillary molar discalization. Now this causes effective molar discalization when compared to functional appliances. So if you want, for a particular case, you want effective molar discalization, that is very much possible with a fixed functional appliance. Ability to modify according to various clinical use is also there. Eating difficulty for about one to 2 weeks is normal. Breakages is a problem. As I said, the slipping of the appliance, the patient has to get used to it. And then ankle loss in teeth, that is a perennial problem in orthodontics. So that is also there in fixed functional. Contraindication, unfavorable growth pattern. So what we call unfavorable growth pattern is a vertical grower. Anything with vertical growth pattern is not very favorable for functional appliances. And children with special needs, again, in terms of cooperation and coordination and stuff is an issue. So that would be the two contraindications. I think I am almost done. I just have few studies that I want to show because I know the time is running. Let me see if there's anything that's specific I want to. Yeah, the pterygoid response we already covered. All you need to do is check for the patient in 2 weeks' time. This is just basically to see if the patient's wearing the appliance or not. So you apply gentle pressure on the chin to see if the patient can push back his mandible, right? And then he'll elicit pain in the condylar region. That is a very, very good point to see whether the patient's actually wearing the appliance constantly or not. Your follow-ups have to be very, very critical when because what we usually tell the patient is to maintain a record in a book, right? They have to write down how many hours of where they are doing in a particular day, and then every day they keep a log of what, especially with headgears, that works brilliantly. So when they bring it back, you have an idea of roughly how long they have been wearing it. However, this is not a very foolproof method. So you could check with the pterygoid response to see if the patient's really wearing it or not. Benefits of functional therapy, I think we did this in the previous lecture. And then these articles also are something that I showed you in the previous lecture. So these articles are very specific to particular, like say, controversies pertaining to amount of mandibular advancement, controversies related to duration of wear of functional appliances. Why should controversies actually exist in functional appliances? This is a very nice point that I want to say, that every individual is different. There's so much of variation between patients, and it is very, very difficult to actually study one particular appliance in, say, a specific number of patients, because the case scenarios are very different. And a lot of these studies that have been done, even by Rabi et al., are all animal studies and histologic sections. So because of that, it is how much can we apply it on human beings is also questionable. And then there is a lot of bias and insufficiencies in methodologies, because each clinician have their own protocols and methodologies that they follow. So again, there is no consistency in that, which again causes a lot of difference in results, right? So that is why all these articles that I mentioned earlier is still not able to come to a final conclusion as to what exactly, whether it works, it doesn't work. And then we also saw the OSA patients, how it helps in OSA patients when you bring the mandible forward and how the airway opens up. So this was just a recap of the morning's session. So what do you do when it is a maxillary problem? When do you address early mixed dentition? What do you give? Headgears, depending on the patient, you choose which headgear you want to give. Effects of functional appliances we just saw in a few slides. This is used when a mandibular problem happens in a class 2 dentition. Again, you do it in late mixed dentition when you want to address the pubertal growth spurt. So to go back, to recap on the roadmap, you identify the patient, you discover that there is an issue, and then you diagnose it with the help of the right investigation. Evaluate the skeletal age of the patient. Once you know when exactly you want to address. If it is a maxillary problem, you address it in C1 and C2. If it is a mandibular problem, you address it in C2 and C3 and C4. You can also do it end of C2. But if you're doing a fixed functional, then it's C4, and you can also try it in C5. So that is with your skeletal maturity indicator. And then you have a final diagnosis. And then you choose the appliance that you want to give the patient, depending on the needs. See if there is aberrant musculature. We'll have to evaluate the tongue. We have to evaluate what is the overbite scenario. Is he a vertical grower? Is he a horizontal grower? Then depending on all that, then we choose the functional appliance. Or are we going to add a headgear to the functional appliance? Is it a combination, like maxillary and a mandibular problem? So you decide. So if you've decided twin block or say bionator or a fixed functional, once you decide the appliance, then you prepare the patient for that appliance. So first we explain to the patient what he's going into, see if you want to do a phase 1 and a phase 2, or is he a class 2 division 2? Then you have to address it first with orthodontics, then with appliance, then again with orthodontics. So all these steps have to be explained to the patient, and then you choose the construction bite you want to do for the patient. So depending on the appliance, depending on his vertical pattern, you decide what is the construction bite we need to make. Once we've decided that, we make the bite, send it to the lab, fabricate the appliance, and we insert it. Then you check the pterygoid response in 2 weeks. Once you know the patient is motivated enough, keep following them up. Mostly in 6 months, you'll see a good change with functional therapy, max 1 year. Sometimes it extends to 1.5 years when there is too much of movement that is required. So then you hold them on a retentive phase until phase 2, where you put braces on to correct the rest of the dentition. So it is going to be a long period. So you have to follow them up consistently and we have to make sure that the retention part is taken care of. And this would be an ideal roadmap for a successful myofunctional therapy. I hope this was clear. I know I ran through a few slides because they were repeat slides from the morning, but if there is anything, I just want to leave some time for discussion. So we can take questions now. I can't hear. I think someone's trying to say something. Sharad sir, someone trying to say something?
Dr. Meera, Dr. Rajesh here again. A yes. Wonderful share. I'm sorry, I was traveling. So during the traveling, I'm listening to you.
No worries, doctor. Please tell me.
The net was going. I wanted you to, can you elaborate on the, how do we touch the inclines and in the twin block, in the first phase, in the twin block?
How do you, sorry?
Or how do we adjust how and when do we need to adjust the inclines?
So initially we don't do anything to the inclines, doctor. So in the first few stages, because if you're going to cause some expansion, right, you're going to allow the expansion to happen for a bit. And it depends on the case, how much expansion you want and all that. So if you want active expansion, you focus on the expansion for the first couple of weeks, and you allow the patient to keep bringing the mandible forward. So because the supraeruption is only for the settling of the teeth and, to retain the sagittal correction. So first, the sagittal correction should happen. So once you know when you take off the blocks, the patient comfortably is biting in the new sagittal position, which would take roughly between 2 to 3 months to be more precise, right? And once that is done, you're comfortable with the sagittal correction, you're comfortable with the expansion that you have achieved, right? So when the patient bites, now you take off the twin blocks. When the patient bites, he shouldn't be biting into a cross bite on the posteriors, because you should have achieved that much of expansion. Once that is done, then you can slowly start trimming your blocks. So there is no clear cut you don't have to follow any clear cut, say, okay, I have to start trimming in the second week, third week. It doesn't matter. Now, say, for example, there's not much of expansion that you require in the patient, and you're only focusing on sagittal correction. And the patient's very good with his appliance, right? Like they're wearing it consistently. You can even start trimming in 1.5 months. So it all depends on how the patient's wearing it and how much of sagittal movement you've achieved.
Thank you, Dr. Meera. Thank you very much.
No worries. So there was someone who sent me an email who wanted to know about palatal expansion. Tejashri, right? Tejashri, are you in the group?
I don't think so, Meera. Maybe I don't know. Maybe she's sitting on YouTube.
Oh,
okay. You can take that question.
She sent an email asking me about some question about palatal expansion. No worries, I'll email her back. Anybody else? Any questions?
I think there was one question.
I just mainly focused on fixed functional and twin block, only because that's something they might want to, and I wanted them to try Bionator, so that's why I spoke a little on that. But if there is anything specific, I can also elaborate.
Like you were talking about this reverse twin block and stuff like that. When we try to do
a reverse, yes, a reverse. You have a reverse activator. You have it even in Frankel. You have, but personally, I've not seen anyone use it. I've not tried it as well, because they're all very old concepts, because that time they always thought the mandibular prognatism has to be addressed. So they were all focusing more on that than the mandibular maxillary being brought forward. But when studies started showing that it's mostly a maxillary problem than a mandibular problem, and the prognatic mandible per se is very, very hard to restrict at that age. You know, if it is a full-blown mandibular prognatism, now they say we just have to address it surgically. But at that time they were trying all this, so it's I would say not effective. We could still try, sir, but it's pretty much clear now in terms of protocol as to what we address. So reverse pull headgear would be a far better option if we are addressing the maxilla.
Okay. No, because I still have this doubt, because what we studied as an undergraduate student, right? What I'm talking is 95, 96.
Yes, sir.
So 25 years before, everything was twin block and a reverse twin block. So if there is a class 2, then the other one is on class 3, then whatever we do for class 3, we can reverse it and we can remember at least for class 1, class 2, class 3 malocclusions, which was our standard essay. But when I came into post-graduation, I realized that it was a little bit different. And when we started talking to our orthodontic friends, right, then we started understanding it differently. I think some of the questions were all related to the same doubts which we have. Again, because I personally know you that you work with the pediatric dentist team, but you are still an orthodontist, and many of the orthodontists, again, with due regards to all the fraternity, but generally the orthodontist would not want the pediatric dentist to touch on certain aspects, not to encroach into certain things. I should put it that way. But why we really wanted to have this particular topic was, again, it's still a gray area. We would like to know our limitations. We would like to know where we should address things earlier and where we should ask the orthodontist to take in, and from then we pass it on to the orthodontist. Let's pass the pattern to the orthodontist. So that's why exactly we wanted you to have that. So can you add, because I think the questions were all answered in your session itself. I think whatever was asked in the previous thing, like about what is your take on myobrace, what's your take on reverse twin block, what's your effectiveness of trainer system, right? So those questions, I think pretty much you have touched upon that. But can you just conclude with your opinion about pediatric orthodontics in mixed dentition by a pediatric dentist? Because I know you have worked with Muthu sir, an entire team of pediatric dentists, and most of us are comfortable working and talking with you because many of the orthodontists still we have a jurisdiction. This is our area. The DCI says 13 years and above, you send it off. And the orthodontic iOS also has specifically mentioned 6 years. Now you have to visit the orthodontist. So everywhere there's hue and cry and hangama about that, but at least your version, not as a political thing, at least to the few listeners who decided to stay back, what is your take on pediatric orthodontist by a pediatric dentist? I think that should summarize it.
Yes, sir. So I think I mentioned a little bit of this in the beginning of the lecture. There has to be a link between the pediatric and pediatrician and the orthodontist, pediatric dentist and the orthodontist. And I'm not saying, so this is only here in India, sir. Like if you go to the West, right? Like anyone who wants to increase their skill set can practice orthodontics. There's Invisalign is available in India, I heard, only for orthodontists. But that's not the case in the North America, right? Because over there, anyone who's trained to do aligners, anyone who's trained to do braces, can perform braces or aligners, provided they've had enough education on it, they've accumulated skill set. So I strongly believe there is no restrictions, sir. Like if a person is interested, like I feel a pediatric dentist is the one who should be treating the child for orthodontics because they already have a rapport with them. They know them in and out. So in terms of psychology, in terms of motivation, in terms of what that patient, that is why I feel that lacuna exists. So they refer it to an orthodontist who I would say has no time or no interest in knowing the patient. They want to do the treatment, right? Like, I mean, I have all regards for orthodontists, but I'm saying they don't have the pediatric touch. I mean, to be honest, they in fact don't even want to deal with children. They're happier treating adults, right? So there they rush it, or there is no enough time for motivation. There is no enough time for explaining to the patient what exactly they're going through, right? So that link is missing over there. The skill part is missing over here. So technically, the patient's not getting something that is wholesome, is what my point is. So if a pediatric dentist increases his or her skill set in orthodontics, even if they don't want to practice it, I truly respect it. But if they increase and widen their knowledge, right, they would benefit the patient far more than referring it to an orthodontist. Because one, they will pick it up early. Two, they can talk to the patient even before they refer them to the orthodontist as to what is required, what they can look forward to. Because, you know, when we refer saying, go to the orthodontist, I think you have some issues with your jaw, you need correction. Now, till the patient sees the orthodontist, that is running in their mind. They go start searching on Google, they find various things, and it's very difficult to undo wrong information when they come to us, right? So I strongly believe pediatric dentists can even go to the extent of treating, because there they do it. Back in the West, it is done regularly. Maybe they don't do full-fledged braces, but all of this is done. Myofunctional therapy, pediatric orthodontics is performed by pediatric dentists there. So it is doable. It is in fact better when it is coming from this side, is my humble suggestion.
Yeah. Thank you so much for that open talk kind of thing. I always like hearing that from you. I think Tejashree has tried to join here in Zoom because I think she wanted to listen to you about the question which is asked.
Okay.
So can you answer the question now?
Sure. Tejashree, I know you sent me an email saying you wanted to know something about palatal expansion. Can you be specific? What exactly?
I think one of the questions which has come here again is about palatal expansion. When I'm using Hyrax, I mostly get dentoalveolar expansions. So do we really get the skeletal expansion as it is expected, or is it only dentoalveolar most of the time?
So, sir, again, there are controversies in this, whether they truly get a skeletal expansion or a dentoalveolar expansion. But as I said in the morning session, as long as we are maintaining why are we concerned whether it's skeletal or dentoalveolar? Because we are worried about relapse. That's the only thing. Ultimately, it is what we see is the teeth. We want expansion in the teeth. We don't want cross bites happening. That's all we need. But why are we concerned? Is it truly skeletal? Because we feel in a skeletal expansion, the relapse will be lesser. Yeah. But like I said in the morning, as long as we maintain the inclination of the teeth to the alveolar basal bone, we don't have to really worry about whether it is skeletal or dental. Now, this is a very small clinical thing that can be possible even on a cast. You don't even, of course, in the X-ray you can confirm it, but on the cast you can definitely mark out what is the initial inclination of the teeth when you cut off posterior to the 7, and okay, if my inclination is already off, when I expand, it's going to become ideal. I'm going to have less relapse. But if my inclination is already ideal, then we have to be very, very careful to make sure that we try and achieve skeletal expansion and minimize. So in that case, I will overcorrect just to make sure that any form of relapse I already accommodated for. So it's very hard to say, are we achieving? We can't, like, even if you see studies and everything, they won't say you achieve 70% skeletal, 30% dental. We can't really pinpoint and say that, but what we are concerned is the relapse. Why are we harping on this? Because we want to make sure there's no relapse. So if we follow this inclination as a key factor, we can minimize relapse, or we can over prepare for it.
Thank you, Meera. But Tejashree, was that the question?
Did I answer her question? So I think she asked between slow.
So we just want to clarify. She's here.
Yeah.
Okay.
So
are you here?
Just to answer between slow palatal expansion and rapid palatal expansion, I think that's what she was trying to ask me. But anyway, I'll wait for her to ask. Between slow and rapid, there is no significant difference. It is the clinician's choice. You want to do slow, you can do slow. If you have enough time to do slow, you can do slow. If you want to do rapid palatal expansion, you can. Because statistically, all the studies have shown, and even in the West, they believe this, that it has no difference. Like, it's not like slow will cause more skeletal expansion or rapid will cause more skeletal expansion. It all depends on the case selection, depending on the inclination of the tooth, like what we discussed. And the age of the patient. That's what matters. So the difference between slow and rapid is your personal choice, just like how you decide between bionator and activator.
Dr. Meera,
yes.
Thank you. Because there are few of us in India working on the myofunction, but very few in numbers. And our deepest gratitude to you for handling the little one also while taking care of,
thank you, sir.
Sharing with us. Thanks a lot.
Thank you, doctor. Thank you. I'm sorry for those interruptions. It's just that we are on a vacation. This is not their environment. So
you don't have to be sorry. It's important to take care of that also.
Yeah, thank you.
Yeah, it's very important. Thank you.
I think someone's sending a message.
Hello. Yeah, I think Tejashree said, thank you, ma'am. Can you hear me?
Yes, I can hear you.
Now, don't worry about the interruptions, because we barged into your vacation. So we literally dragged you into our CDE program. And I'm sure most of the attendees have actually benefited out of this program. Thank you so much, Meera.
I hope so. I hope it conveyed something to you all. And even if you do one step more than what you're doing until today, I would be very, very happy for it.
Yeah. Thank you so much, Meera, for this.
Thank you, sir.
Can you see this certificate of us?
Yeah. Thank you.
Okay. Yeah, thank you so much, Meera, for accepting our invitation. I know it was like literally dragging you into this, but You
Sir, well,
kindly
thank you.
accept
Thank you
it.
for the opportunity, sir. Always grateful. Thank you.
Yeah, thank you. Thank you so much. Yeah. I just want to take one picture with whoever is
Yes.
still there around. So if it's possible for request all participants to Dedipya, a long time since I met you. Nice to have seen you here also. Yeah, I think a lot of participants stayed back actually post lunch session and this thing. Because actually when we started it was
biofunctional. So
no, actually it started with 43 when we started. It went on till 60 plus, and there were about 20 people. So even when we organize any webinar, 50, 60 people sitting together till the end, I think unless it's good, then nobody would really want to do that. So yeah, thank you so much.
Thank you everyone for your time, and I'm happy that I was able to do this. Thank you so much.
Yeah, Dr. Kavita is here. She's heading the department in SRM.
Oh, hello, doctor.
Yeah.
Hello, ma'am. It was very nice. Initially, the first session I missed because I was the last. So after our seminars, I couldn't do, but it was excellent. The full session I was there after that. It was so nice.
Thank you so
much. It was
much.
very practical. The way you explained was awesome.
Thank you, ma'am. Thank you.
It was very nice. Very humble of you. Thank you.
Thank you so much. Thank you.
Anybody wants to say something directly to Meera, you can actually, instead of putting thank you, we would all like to hear something from us. Yeah.
Ma'am, it was
A lot
very
of faculty members are also there. Yeah.
It was very informative, Meera ma'am. Especially like as you said, instead of referring the patients to orthodontists, I think we can take the first step and diagnose and explain them what is need to be done. As you said, like the more complicated things we can leave it to them, but this myofunctional area, I think we can grab it.
Yes, definitely. You should.
Yes.
Thank you, Meera. Thank you so much. Thanks to everybody.
For your time.
Yeah.
Thank you.
Yeah, actually, I was supposed to propose the vote of thanks. Then I would like to thank my head of the department, Dr. Geeta Priya, for organizing this event. The entire department team, Pedo, we call ourselves. So the management and everybody who's worked for it, Dr. Prasad, who's helping us with this technical aspects. Thank you so much for joining us today. Thank you. Thank you, Meera.
Thank you, sir.
Yeah,
thank you, everyone. And thank you, Sharat, sir, once again for this opportunity.
Yeah, we will keep troubling you. We'll keep troubling you. Yeah, sure. Thank you.
Thank you all. Bye-bye.
Bye-bye.